Hello, my name is Izolde Bouloukaki. I'm a general practitioner and somnologist, expert in sleep medicine at the University of Crete School of Medicine in Greece. Welcome to this lecture. My focus of my presentation today will be on obstructive sleep apnea, otherwise OSA. I will start the presentation with the diagnostic criteria for OSA, then move on to the different pathophysiological traits and phenotypes of OSA. Next, we will focus on complication of OSA and review guidelines for clinical evaluation and diagnosis. Finally, we will discuss the various treatment options available for OSA. OSA is widely acknowledged as one of the most common chronic respiratory diseases in adults seen in clinical settings. The diagnosis of OSA involves measuring breathing during sleep. Diagnostic criteria for OSA require either 15 or more obstructive respiratory events per hour of sleep or a combination of symptoms and comorbidities and at least 5 but less than 15 obstructive respiratory events per hour of sleep. This definition indicates that there are also patients who present with OSA without symptoms. The clinical presentation of OSA is a result of the underlying physiological mechanisms known as endotypes. The endotypes currently accepted include anatomical compromise of the upper airway, unstable ventilatory control or increased loop gain, low arousal threshold, and pharyngeal dilator muscle dysfunction. The contribution of each of these endotypes to the pathogenesis of OSA is individualized to each patient. General population-based studies have consistently shown a high prevalence of undiagnosed OSA. The prevalence of OSA in different studies conducted globally has been reported to be approximately 22% among men and 17% among women. The difference in prevalence between men and women appears to fade after menopause in women. Other factors that additionally influence the prevalence of OSA are age and obesity. A detailed sleep history is essential when evaluating OSA. While clinical symptoms play a crucial role in identifying OSA, none of them are deemed pathognomonic. Snoring is often reported, but there are also numerous symptoms that can be experienced both at night and during the day. Additionally, these symptoms typically have a subtle onset and gradually worsen over the course of several years before referral for evaluation. Most patients with OSA first come to the attention of a clinician because of reported daytime sleepiness. It is important to carefully consider situations where the patient's sleepiness impairs their ability to perform daily tasks, posing a potential threat to their job and driving safety. Patients also often report experiencing non-restorative sleep, fatigue, memory impairment, lack of concentration, decreased libido, mood disorders, and dry mouth. Morning headaches and clinically significant symptoms of insomnia, specifically sleep maintenance insomnia, have also been reported in patients with OSA. Next, we'll turn our attention to adverse outcomes associated with untreated OSA. Evidence supports a causal association of OSA with the development of several adverse outcomes, which potentially over time lead to impaired quality of life and increased mortality. This includes cardiovascular and metabolic disease, depression, and exacerbation of comorbid diseases, resulting in substantial burden on the healthcare system. These outcomes are linked to different biological pathways, including chronic intermittent hypoxemia, sleep fragmentation, hemodynamic disturbances, and alteration in sympathetic activity. Moreover, OSA has been established as a causative factor in traffic accidents. The European Respiratory Society established a task force to address this topic to provide clinicians treating patients with OSA with an overview of this disorder. It's crucial to understand that the clinical spectrum of OSA now far surpasses the classical picture of the male, obese, and sleepy patient. This change in the population at risk for OSA affects diagnostic strategies because some patients are more difficult to diagnose. A strategy to deal with this diversity involves categorizing symptoms along with comorbidities into clusters, allowing for the recognition of a clinical phenotypes with specific characteristics. The significance of clinical phenotypes lies in their ability to identify patients who are at heightened risk for cardiovascular disease, classify the severity of OSA, and design individualized treatment plans. Additionally, they help us differentiate between individuals who respond favorably to therapy and those who do not. Presently, there is no consensus on the classification of OSA into distinct phenotypes. A categorization of possible OSA phenotypes that are clinically significant is presented, taking into account symptoms, gender, age, and ethnicity, and their association with predominant endotypes. It is worth noting that in the past, sleepiness was regarded as a prominent feature of OSA. However, recent research identifies 3 distinct phenotypes based on symptoms: patients with insomnia-related symptoms, those who are relatively asymptomatic, and those who experience excessive daytime sleepiness. Women with OSA typically exhibit non-specific symptoms such as insomnia, depression, fatigue, morning headaches, and nightmares. However, there is consistent evidence regarding the presence of snoring, apneas, and excessive daytime sleepiness. Other patients at risk for OSA are those with cardiovascular disease, those being evaluated for surgery, patients with respiratory conditions like COPD, asthma, and idiopathic pulmonary fibrosis, as well as individuals with endocrine disorders like diabetes type 2. Once we have identified the population at high risk for OSA, it is important to utilize appropriate screening tools. Having a 2-step process with patients screened first with a comprehensive sleep history, along with sleep questionnaires, and then with nocturnal pulse oximetry could increase pretest probability of OSA and prioritize high-risk patients to sleep center for diagnostic study. Polysomnography is the standard medical test for the diagnosis of OSA in adult patients, and the home sleep apnea test is an alternative medical test for the diagnosis of OSA in uncomplicated adults presented with signs and symptoms that indicate an increased risk of moderate to severe OSA. Oximetry is of limited diagnostic value. To diagnose OSA in patients with significant cardiorespiratory disease, potential respiratory muscle weakness due to neuromuscular condition, awake hypoventilation, suspicion of sleep-related hypoventilation, chronic opioid medication use, history of stroke or severe insomnia, the American Academy of Sleep Medicine Clinical Practice Guideline recommends using polysomnography rather than home sleep apnea testing. Clinical tools, questionnaires, and prediction algorithms cannot be used to diagnose OSA in adults in the absence of polysomnography or home sleep apnea testing. The severity of OSA is expressed by the apnea-hypopnea index, which reflects the number of episodes of apnea and hypopneas per hour of sleep. OSA is considered mild if the apnea-hypopnea index is equal or above 5 per hour but less than 15 per hour, as moderate if the apnea-hypopnea index is equal or above 15 per hour but less than 30 per hour, and as severe if the apnea-hypopnea index is equal or above 30 per hour. However, this classification is facing criticism as it does not account the severity of the saturations, the distribution of episodes based on body position or sleep states, the age of the patients, the presence of symptoms, and any coexisting morbidities. Future assessment procedures are currently being given attention and are undergoing evaluation. Finally, I'd like to address the topics of treatment of OSA. The goals of OSA therapy are to resolve signs and symptoms, improve sleep quality, and normalize the apnea-hypopnea index and oxyhemoglobin saturation levels. The potential benefits of successfully treating OSA include clinical improvement, for example, less daytime sleepiness, reduced healthcare utilization and costs, and possibly decreased cardiovascular morbidity and mortality. Several national organizations have published clinical practice guidelines for the management of OSA in adults. Weight loss, exercise, smoking cessation, abstinence from alcohol and sedatives, and avoiding the supine sleeping position should be recommended to all patients with OSA. Common to all guidelines is the recommendation that all patients should be offered positive airway pressure or PAP as initial therapy. The purpose of the PAP device is to provide mechanical ventilation by delivering PAP through a mask interface and acting as a pneumatic splint to support the upper airways patency. PAP has the potential for high effectiveness, but considering the relatively low acceptance and compliance, its actual impact and utilization are relatively limited, which supports the exploration of reliable alternatives to PAP, offering the potential for more individualized therapeutic approaches. In 2018, a group of European experts published a novel method of OSA classification in which the apnea-hypopnea index is not taken into account to start treatment. According to this classification, patients can be classified into one of four groups, A, B, C, or D, depending on the severity of the OSA symptoms and the presence and severity of comorbidities. It is important to note that a range of alternative treatment options exists for OSA, including oral appliances, surgical procedures, including bariatric surgery and hypoglossal nerve stimulation, myofunctional therapy, and pharmacological therapy. Although not as efficient as PAP devices, oral appliances can be advantageous in maintaining the mandible in a forward position, thereby preventing the collapse of upper airway muscles. This is particularly beneficial for patients with mild to moderate OSA, as well as those who cannot tolerate or do not respond to PAP therapy. In cases where there is a correctable anatomical abnormality, surgical approaches may also be considered. Additionally, pharmacological agents have been evaluated that target different endotypes of OSA and have shown potential benefits, but none have been approved for treating this condition yet. Overall, successful management of OSA requires a comprehensive, personalized, and interdisciplinary approach with regular follow-up visits. In the future, telemedicine has the potential to revolutionize healthcare by providing personalized and digitized treatment pathways. In conclusion, let me briefly summarize the main points. The diagnosis of OSA involves measuring the whole spectrum of breathing during sleep as well as the different pathophysiological traits, meaning and detailed phenotype. It is important to recognize that one size doesn't fit all. Women with sleep apnea present differently from men and are harder to diagnose. There are different clinical phenotypes with probably different risk for cardiovascular or metabolic disturbances. There are therapeutic options beyond PAP, however, the therapeutic plan should be based on the following principle: careful assessment, diagnosis, and severity classification, individualized therapeutic plan, and close follow-up from accredited sleep specialists on centers. Following this presentation, there will be assessment. You will work in small groups to prepare a case presentation on OSA. Each group will present a hypothetical case, including the patient's history, diagnostic findings, and proposed treatment plan. This assessment will evaluate your understanding of the disease, treatment modalities, and ability to communicate effectively with peers. Thank you so much for your attention.